1:30 on my computer, so I will turn it over to you, Sarah.
Okay, welcome everyone. Thank you for joining us today. My name is Sarah Rowan, and I'm an infectious disease doctor at Denver Public Health, and I'll be facilitating the session today. So in response to the evolving COVID-19 pandemic, which is now in a phase that we have never seen before, with incredibly high rates around the whole country, and yet some good news from two vaccine studies. We have an ever-changing situation, so we've developed this COVID Echo Learning Series. This is a bi-weekly virtual learning community for the Mountain States to address COVID-19 management issues in our region. We welcome you all to session 5 today, and as always, invite you to forward the registration link to other colleagues you think would be interested in attending. Today, our speakers will be covering COVID-19 employee infection prevention policies. Remember, our topics will change every session, so please come back for continued learning opportunities. You are welcome to suggest future topics, comments, and opportunities to better serve this group by way of evaluation or sending Victoria or Carolyn an email or just using the chat box. As our presenters speak, we strongly encourage you to enter questions about the presentation in the chat box for us to address during the Q&A session at the end of the presentation. And of course, that's not required. You're also welcome to just speak up during the discussion session. Before we get started, we want to acknowledge this is a joint collaboration between the National Emerging Special Pathogen Training and Education Network, the NETEC, Denver Health, Denver Prevention Training Center, Robert Wood Johnson Foundation, and Project ECHO. My name is Sarah Rowan, and I'm one of your facilitators, as I said before. And today's agenda will start with a tech check from Victoria. We have 2 short presentations followed by a panel discussion with time for questions and answers. So I will turn it over to Victoria for the tech check.
Great, thanks, Sarah. So as always, you all can unmute by clicking the unmute or mute button down in the lower left part of your screen. Again, that'll be depending if you are muted or unmuted right now. Next to that is the button I always encourage you all to push 24/7, I feel like, which is start video. Being on camera really makes it interactive for us. We love it. You're probably so tired of hearing that, but I promise I'll stop if everybody comes on camera more. And as always, we have our chat box. If you want to go ahead and put where you're calling in from, it lets our speakers know where everyone is at. So I just put in there that I'm from Inglewood. And with that, I just want to remind you that our website, which I'm going to paste right now into the chat, but may get lost in some of the cities, is where you can find all of our resources after the session. So please feel free to go to that website at any time and download them. And I'll turn it back over to you, Sarah.
Okay, so moving on to our first presentation. Our first expert presenter is Karen Wendell, who is the director of the Division of HIV and STD Prevention and Control at Denver Public Health, and she's an infectious disease specialist, also the co-facilitator of this program. And she'll discuss COVID-19 and healthcare workers and implications for coworkers and patients. Karen, it's all yours.
All right, thank you. Can you hear me?
Yes.
All right. So thank you for coming today. We are just going to give you a little bit of a backdrop before we move on to our guest speaker. Clearly, when we think about COVID-19 and healthcare workers, we're concerned not only about protecting the health of our healthcare workers and their morbidity and mortality, but maintaining health system capacity to do the work that we need to do to serve our communities and reducing secondary transmission within hospitals and assuring that we don't have nosocomial spread of COVID-19. I'm going to talk a little bit today about how COVID-19 has been affecting healthcare workers and also how it's been affecting the work that we do in taking care of our patients. When thinking about COVID-19 exposures for our healthcare workers, they are quite extensive. Of course, we have exposures to patients, both those that we recognize as having COVID-19 and those that are asymptomatic or pre-symptomatic that are not yet diagnosed with COVID-19. Our healthcare workers are exposed in their homes when their loved ones have illness. We have community exposure. And finally, I think the one that's more insidious and the one that is less recognized and that we tend to let our guard down to is exposure to coworkers who may have COVID. So in looking how, with this myriad of potential exposures that healthcare workers have, how they have been affected by COVID-19, we have a few lines of evidence to review. This study was published by Self and colleagues and really looked across a diverse geographic area of academic centers, 13 in total, and did seroprevalence study and took an EIA to the spike protein and looked at the positivity in healthcare workers at these institutions and surveyed over 3,000 healthcare providers and found that overall the positivity with this assay was 6%. It was a highly sensitive and specific assay. However, as we all know, this type of seroprevalence assay is limited by the length of positivity of antibodies after having COVID infection. The institutional range was quite wide. So overall positivity, thankfully, was low at 6%. But you can see by institution, it varied from 0.8 to 31% of the healthcare workers that they surveyed with a median of 3.6%. And this gives you a look, and I'm sorry, this is rather small, at the different institutions that were involved in this study. And you can see that the highest percent positivity in healthcare workers came from Montefiore Medical Center in the Bronx. And overall, there is some correlation with the positivity in our healthcare workers and community incidence of COVID-19, as you might expect. But some institutions seem to do really quite well, even in the setting of fairly widespread community involvement. You can see here the rates at Johns Hopkins, less than 5%, and Beth Israel around 5%, with relatively high rates of COVID in the community. What this study demonstrated is that of the healthcare workers who had COVID-19, 29% had no symptoms. So with seropositivity, 29% with no symptoms, 69% had not had a previous COVID-19 diagnosis. And as you might expect, that seropositivity was lower in folks who reported consistent mask use around patients compared to those who did not. So 6% among those who had regular mask use and 9% among those who did not. And similarly, the study demonstrated that shortages in PPE were really correlated with higher degrees of seroprevalence of COVID in their healthcare worker population. But moving into this idea of how we protect ourselves really in the facility to prevent nosocomial spread and really protect ourselves as we are kind of working with our colleagues and potentially taking off our PPE for relief, for a break, how does this impact us and how does it impact COVID transmission in the workplace? This study really was done in Turkey and demonstrated associations on univariate analysis of COVID positivity in their healthcare providers being associated with working on a COVID-19 unit, taking care of SARS-CoV positive patients, and having positive COVID patients in their household, inappropriate use of PPE, and then interestingly, staying in the same personal break room with a healthcare worker without a medical mask for more than 15 minutes. So having that exposure, a meaningful exposure in the workplace and not protecting ourselves sufficiently, consuming food within a meter of another healthcare worker with COVID, and failure to keep a safe social distance with healthcare workers with COVID. On multivariate analysis, the things that really popped were, of course, inappropriate use of PPE around patients with COVID-19, and this using break rooms with other healthcare workers without wearing a medical mask for more than 15 minutes. In looking at data closer to home, we have a study that was published in the MMWR from Minnesota. Minnesota has a centralized reporting system, and so healthcare workers are from over 1,000 different participating healthcare facilities were reporting their exposures centrally to Minnesota Department of Health. They had reports of exposures from over 20,000 healthcare workers. And of those, they classified over 5,000 or 25% as high risk exposures. And they categorized those to really identify what are the most important exposures that we're seeing that are meaningful in our healthcare worker population. And I think this was interesting that of the over 5,000 exposures that were deemed to be high risk, 34% of them were occurring in non-patient care settings. So 14% were attributable to a coworker with COVID, and then social and household contacts attributing to 19%. The other 66% were attributable to direct patient contact, And you can see that the majority of those being in congregate outbreak settings or long-term care settings to a single patient. Acute or ambulatory care settings really made up the minority of exposures across this entire survey from the Minnesota Department of Health at 26%. So looking at this a little bit more closely, healthcare workers with COVID-19 tended to expose a median of 2 other coworkers prior to recognition of their illness. So the interquartile range being 1 to 3. So really showing that this is a real meaningful type of exposure that can occur in our healthcare settings and something that we need to be mindful of and remind all of our colleagues of. Looking at which high-risk exposures were the greatest risk to actual positive SARS-CoV testing in our healthcare workers at follow-up. We see that contact with household or social contacts was the highest positivity rate. The overall rate, thankfully, of getting SARS after an exposure was 7%. But if it was a household contact or social contact, those healthcare workers had a positivity rate in the next 14 days of 13%. They did do a stratification of the data, looking at congregate or long-term care settings versus acute care settings. And as we might expect, there were some differences. And so in looking at the patients or the healthcare workers that became patients who were COVID positive, looking at how many of them worked after their exposure and didn't really have the luxury of following a quarantine and staying at home, we see that it was 57% worked after their exposure in long-term or congregate care settings, 37% in acute care settings. I think many of us are experiencing this now due to shortages in staffing and a need to keep our patients cared for, both for nurses, providers, and other healthcare workers. In looking at how many folks worked symptomatically, thankfully that was quite low, but still close to 5% of the healthcare workers in long-term care settings were working while symptomatic, with only 1.3% in acute care settings. And there was a difference in how many of these folks after their high-risk exposure did contract COVID, 9.6% in the congregate long-term care settings and 3% in the acute. So in looking at how this affects the patients that we care for, there is not a lot of data, but Baker and colleagues took a look at both acute care settings and outpatient settings and looked at a total of 253 potential exposures of patients. They had 27 that they couldn't really follow up due to having been deceased within the 14-day follow-up period or unable to contact these patients after discharge. But they were able to follow 226. What they found were 2 cases that were clearly tested positive for COVID after an exposure to an infected healthcare worker. Of these 2, only 1 was clearly related to the healthcare worker. And of note, it was this one case occurred prior to universal masking in healthcare workers, really suggesting that sick healthcare workers, when properly masked and with a proper PPE, don't have a high rate of infectivity to the patients that they're caring for based on this small study. So in this study, less than 1% transmission to patients. But as you can see, not everyone did receive a test. So they had 37 symptomatic patients. 34 of them were tested and were negative. 187 never developed symptoms. Only 54 of those were tested and all were negative. I think this study really looking at nosocomial spread over duration of the outbreak suggests that we can control nosocomial spread with really good PPE and with infection control practices, similar to this study that was looking at patient exposures. This is looking at cumulative hospital cases in the large bars of COVID-19 and late onset cases that were found within the hospital that may have represented nosocomial spread. And you can see in this institution and down below are sort of the PPE and infection control measures that they took over time. In this institution, they were very well able to control these late onset hospital cases. And in fact, some of these we might anticipate may have been related to exposures just prior to admission. But nevertheless, you can see that there was little to very little nosocomial spread within this institution. In looking at this, we might say that when we reach these high levels of COVID circulation within our community, so unfortunately we are once again closer to this extreme and mitigation phase than we are into a containment phase. We know that our healthcare workers are being infected not primarily from patients unless there's been a clear breach in PPE, but more from community, household, and social contacts, as well as exposures to other healthcare workers. And so it's very important for us to be reassuring our healthcare workers about how effective our PPE measures are, but also reminding them to be very careful in settings where they are potentially letting down their guard around other healthcare providers, and also in community and social circumstances. So I would just say in summary, some of the recommendations that came out of Minnesota, I think hold true looking across all of this data, that consistent PPE availability and use is the highest priority for our healthcare workers. We need to have flexible sick leave and to staff appropriately so that we are able, whenever possible, to prevent healthcare workers from working when they're symptomatic or when they could be on quarantine for an exposure, for a high-risk exposure. To provide ample and rapid results to SARS-CoV testing, and to be vigilant about non-patient exposures, including coworkers, household members, and social contacts. And with that, I'm going to turn it back over to Sarah Rowan.
Thank you, Karen. That was a fantastic overview. So I just want to remind everyone that if you have questions, burning questions, feel free to put them in the chat now so that we can go back to them at the end of the presentations. And so I would like to move now to our second speaker, which we are very honored to have here. Dr. David Kuhar is our next speaker. He is the team lead on the hospital infection prevention team in the Division of Healthcare Quality Promotion at the CDC. And he will be discussing healthcare personnel SARS-CoV-2 management recommendations from the CDC. And so I will now mute and turn it over to you, Dr. Kuhar.
Thank you. Thanks for having me speaking today. So there are many guidance documents on the CDC website that contain recommendations for healthcare personnel about SARS-CoV-2 infection prevention and control. And they are numerous and diverse. And I'm going to touch on only a few of the major guidances for this brief presentation. And all that I mention are available on the CDC website. And after the call, I'm going to send in links so that the guidances can be easily available to everyone. So the first that I need to mention is in the interim infection prevention and control recommendations for healthcare personnel during the coronavirus disease 2019 pandemic. This contains the recommendations for both routine infection prevention and control practices during the pandemic, such as those encouraging telehealth visits, triage and screening of everyone entering a healthcare facility, the need for universal face masks in healthcare for source control, including needing them being needed by healthcare personnel, as well as encouraging physical distancing for healthcare personnel, designating areas and staggered schedules for personnel to take breaks, eat and drink that allow them to remain 6 feet apart from each other, especially when they need to be unmasked, as well as other recommendations that are intended to be baseline practices during the pandemic. Now, it also includes practices about caring for a patient with suspected or confirmed SARS-CoV-2 infection, including patient placement, which is a single patient room, recommended personal protective equipment for when entering the patient care area or their room, a gown, gloves, eye protection, and a respirator. If a respirator is unavailable, face mask can be used, as well as recommendations on specimen collection and environmental cleaning. Now, the guidance is among, I would say, the most critical with which to be familiar. There are also dedicated infection control guidances for long-term care, dental, assisted living, dialysis settings, and others. However, between all of these, the main principles about infection prevention and control remain the same. They are simply tailored to those individual additional settings. Now, the interim US guidance for risk assessment and work restrictions for healthcare personnel with potential exposure to COVID-19 details evaluating exposures that occur in healthcare settings, and but importantly recommends that personnel with higher risk exposures are to be restricted from work for 14 days. They're not to come into the facility at all. For lower risk exposures, work restrictions are not recommended, and the guidance has a table that gets into personal protective equipment worn, as well as types of exposures that might happen in healthcare to make this clear, and it's another really important one with which to be familiar. Now, moving to the management of personnel who are household contacts of cases, the strategy for work restrictions in healthcare aligns with guidance for community exposures. Exposure is defined in several different CDC guidances, and for the household, the definition of exposure is in the guidance entitled Public Health Guidance for Community-Related Exposure. And exposure is defined pretty simply as an individual who has had close contact, meaning being within 6 feet for just a total of 15 minutes or more, with a case while they're contagious. And this would include persons who have COVID-19 with symptoms, and their period of contagiousness is typically 2 days before the onset of symptoms, which is important to remember, as well as persons who just test positive for SARS-CoV-2, so they're confirmed positive, but they've not had any symptoms. And you typically consider them contagious for 2 days before the collection of that specimen. Now, for healthcare personnel who are considered exposed, and as well exposed in the community, exposed in healthcare, the recommendations are stay home until 14 days after the last exposure and maintain a social distance of at least 6 feet from others at all times. They're to self-monitor for symptoms, instructed typically to take their temperature twice daily and watch out for fevers and other symptoms of COVID-19, avoiding contact with people at higher risk for severe illness, such as the elderly, people who might be immunocompromised. And if they do develop symptoms, they're encouraged to discuss that, especially with occupational health services. Now, I think important points to clarify, does testing or the use of testing for SARS-CoV-2 in any way affect recommendations for work restrictions? Can they come back earlier if they agree to be tested? And ultimately, the answer right now is no. There aren't recommendations from CDC that allow for that at this time. Do the areas in which healthcare personnel work, like working in the ICU versus wards versus an outpatient setting, affect recommendations for work restrictions? And again, in short, no, they don't. The bottom line is a conservative stance is taken for personnel, and restricting them from work is really the key in preventing outbreaks in healthcare, as these can be devastating. So the recommendations for managing a provider that's a household contact of a case are fairly straightforward. However, what happens when so many personnel are exposed or ill that there aren't enough staff available to provide safe patient care or resident care anymore? And this has been a very real problem in some areas during the pandemic already, and will continue to be. So CDC has developed a guidance entitled Strategies to Mitigate Healthcare Personnel Staffing Shortages. And this is another important one with which to be familiar. Now, the guidance provides contingency capacity strategies to mitigate staffing shortages. And this is for when staffing shortages are anticipated, but not yet happening. And crisis capacity strategies for when staffing shortages are in fact occurring. Now, the guidance is intended to be incrementally implemented, meaning using contingency capacity strategies first, before using the crisis strategies. Now, the contingency capacity strategies include actions such as canceling all elective procedures, having staff postpone planned time off when possible, and working to identify additional staff, say through local healthcare coalitions or other areas, who may be able to fill staffing gaps. Additionally, it includes emphasizing developing all of these plans, but also developing plans that might allow asymptomatic healthcare personnel who have had an exposure to SARS-CoV-2 but are not known to be infected to continue to work. And just remember, this is about developing the plan in a contingency, but not bringing them back to work yet. As part of that plan, post-exposure testing of exposed personnel is mentioned at a high level in the guidance as a part of developing those plans. And the guidance indicates that when testing is readily available, performing post-exposure testing during that 14-day post-exposure period or incubation period could be considered to more quickly identify pre-symptomatic or asymptomatic personnel who could contribute to SARS-CoV-2 transmission. They also state that for facilities that elect to perform post-exposure testing should be aware that testing might be logistically challenging and has a lot of limitations. For example, testing only identifies the presence of virus at the time of the test. It's possible that healthcare personnel can test negative because they're still incubating disease when their sample is collected. And in such situations, they can become infectious later and transmit the virus to others. And so for that reason, if developing plans to test, you could consider repeat testing on a regular schedule. If testing of exposed personnel is used as a part of a contingency capacity plan that's developed for when there's a crisis, the results also need to be rapidly available. I mean, you need them quickly. Within 24 hours, you don't want to keep sending tests and then not getting the results. And you have to have a clear plan in place on what you're going to do with the results. How are you going to manage a positive test? This all has to be planned out before doing something like this. And I would say this would bring me to crisis capacity strategies for when staffing shortages are actually happening. There are no longer enough staff to provide safe patient care. Actions here, and from the guidance, actions here can include implementing those regional plans to transfer patients, say with COVID-19, to other designated healthcare facilities or alternate care sites that do have adequate staffing. Implementing those plans that could allow asymptomatic personnel who have had an unprotected exposure but are not known to be infected to continue to work. And then as a last resort, if shortages continue, despite all of the other mitigation strategies, considerations for allowing personnel with suspected or confirmed COVID-19 who are well enough to work and willing to work, but are still contagious to others can be thought about. And if personnel are allowed to work before meeting all criteria to where they're not considered contagious, they need to be restricted from contact with severely immunocompromised patients, and facilities need to consider prioritizing their duties, and they even suggest an order in which this can be done. First, maybe allowing personnel with suspected or confirmed COVID-19 to perform job duties where they do not interact at all with others, such as picking up telemedicine services, and those who are well and performing telemedicine services might be prioritized for the inpatient care. Second, allowing personnel with confirmed COVID-19 to provide direct care only for patients with confirmed COVID-19, or really I should say confirmed SARS-CoV-2 infection, performing care for only patients with confirmed SARS-CoV-2 infection, preferably in a cohort setting so they're still separated from everyone who is uninfected. Third, allowing personnel with confirmed COVID-19 or SARS-CoV-2 infection to provide direct care for patients with suspected SARS-CoV-2 infection. And as a last resort, allowing personnel with confirmed infection to care for patients without suspected or confirmed infection. And this is a situation that we really don't want to see happen. So, and what I want to say, it's really important to remember the intent of this guidance about mitigating staffing shortages is to allow for a crisis to be managed, but it is not to provide global permission to just ignore work restrictions that are warranted when things are tough or without a crisis occurring. It is not intended to be, there is risk in using these, and people need to recognize outbreaks can happen because of them. Keeping our potentially contagious personnel out of the workplace is really critical to preventing transmission there. That's probably our best defense. And then finally, as a last point about testing, healthcare personnel information, and confidentiality. Confidentiality of healthcare worker information, test results, et cetera, is of the utmost importance. I am not aware of actually direct SARS-CoV-2 guidance about this, but there is a guideline for infection control in healthcare personnel that discusses the topic, and it has a section on management of healthcare personnel health records, which includes discussion about the importance of confidentiality in maintaining personnel confidence in an occupational health program. And it discusses things at a programmatic level, and it provides some suggestions on how to maintain confidentiality, such as keeping personnel testing results and records in a completely separate system than patient records, which ensures that friends and colleagues don't unintentionally access their information and helps to boost their confidence that you're taking their confidentiality seriously. But again, all of the recommendations, that guideline I say are programmatic level and fairly high level. And with that, I will stop. Thank you.
Thank you very much for that very thorough overview with some kind of more pragmatic considerations. And as you mentioned, the challenges are, they're only getting more and more as we see this epidemic at, like I said, new levels that we haven't had to experience before. I want to acknowledge a few folks that are in the session now who have some expertise and experience in this matter. Dr. Bill Berman from Denver Public Health, Dr. Heather Young, the Director of Infection Prevention at Denver Public Health. We also have Jim Nide, who is an infection prevention and infectious disease specialist, as well as Dr. John Hammer. Thank you all very much for joining. I noticed that we also have Tiffany Martins, who's in infection control out in Grand Junction. We have some University of Colorado representation. And a shout out to our colleague out in Billings, Montana for the Montana perspective. So I just want to invite you all to join in this discussion, given your various roles in decision-making and crafting these very, very challenging policies right now. I wanted to go ahead and just go right to Dr. Berman's first question and kind of put this out to the group. Bill, would you mind unmuting and asking your question?
Sure. Two things. One is I wonder if antibody testing could have a role, because now that we have the demonstration that antibody means something, that is vaccination work. So presumably prior infection provides a substantial degree of protection. The other reason I think about antibody testing is that the modeling group at the School of Public Health here estimates that for our county, 20% of the people have been infected by this point in the epidemic. And so one possible strategy for a healthcare worker is to see if they have antibody. If they have antibody, figure their chance of developing transmissible COVID in the next 2 weeks, probably in the next 6 months, is extremely low. And could that allow them to go back to work safely in the setting of having had, for example, a high risk like household exposure? The other thing I was just starting to type in is, of course, we're weeks away from vaccinating frontline hospital workers. And so when do we consider that frontline hospital workers have protection from the vaccine that they may be getting by mid-December?
And I'll open that up to anyone who wants to answer from either the CDC high-level perspective or the on-the-ground perspective in terms of how different people are approaching using the tools that we have.
Well, if okay, I'll take a first stab at this. I'll say for Dr. Berman's questions, I mean, these are dead on, and I think there are great points here. And I would say I would anticipate that within the next few months, we will likely be seeing guidance updates that I would think are going to really have to address all of the questions. I know there are discussions currently on how we might improve the use of testing for earlier return to work happening in CDC. And obviously, as we are approaching use of a vaccine, we absolutely when are healthcare personnel considered immune and how that affects exposures, et cetera, has to be addressed.
Yeah, it just seems like we're discussing things like testing people every few days or something like that as a strategy, using rapid antigen tests or maybe PCR. But if you did an antibody test at the very beginning of that consideration and somebody's antibody positive, my guess is, more than a guess, I think there's good evidence that their chance of developing infectious COVID is very, very, very small. And hence that test could be much more useful than a negative rapid antigen, for example, which, as you pointed out, only tells do you have high-level virus in your respiratory secretions today, and says not much about the chance of that developing over the next week or two. So that's the reason I come back to the question we've pondered since May of what do you do with antibody tests?
I wonder if any of the other kind of infection prevention experts would want to sort of comment on that, or even sort of the use of testing in general, the antigen or the PCR test in the return to work strategies. Not a lot of takers on that one. Let's turn to Erica's question. Erica, do you want to unmute and ask your question? Actually, it looks like you have two excellent questions.
Thanks. Yeah, my mind just keeps going, you know how it goes. So we have not had to institute bringing back exposed employees yet. However, as everybody in the state is preparing their plan for the governor, one of my questions is there a stepwise approach to bringing back healthcare workers, those that are quarantined that are not positive but are asymptomatic? Should those come back first, then possibly the asymptomatic COVID positive patients, and then of course the COVID positive symptomatic should not come back at all? Is that kind of a strategy that is recommended or going to be employed or looked at? My second aspect is about the antibody testing. People are getting reinfected. So how is a vaccine going to protect everybody from other mutations? And is there any potential in just instead of positive or negative antibody, is there a titer as in, you know, hepatitis and et cetera, where we have titers to show immunity, that type thing? So sorry, this is, I know, big grand questions, but.
Erica, I'd be happy to try to take on your second question. I don't know how the vaccine is going to perform in terms of how long a antibody is going to be detectable. But certainly what we know about the people who have a second COVID infection is that the symptoms are generally extremely mild, or they are asymptomatic from it. And data from South Korea suggests that these people don't spread it to others, or at least spread it to others extremely rarely. There's a really nice article in the CDC South Korea that describes their experience with almost 300 patients with a repeat infection, and just shows that they, first of all, don't shed live virus. Second of all, epidemiologically don't spread it to other people. And in terms of your first question, I will take a stab at that one as well. So the place that I work, I'm at Denver Health. We actually still don't quarantine healthcare workers who are exposed to COVID because we would not have enough workforce in order to take care of our patients. But we certainly don't allow asymptomatic healthcare workers who are potentially contagious with COVID or symptomatic healthcare workers with COVID to come back to work until they've cleared their 10 days afebrile and also with symptoms improving. But yeah, we are allowing those who are exposed either in the community or at work to continue to work, provided they remain asymptomatic.
That's very interesting. And that's solely based on a staffing algorithm, that you wouldn't have enough staff if you did quarantine them? Or is that a new recommendation that healthcare workers that have had exposure that are quote unquote quarantinable can work? Because that would help us out quite a bit.
So it's clearly against the CDC's recommendation. It was consistent with the CDC's recommendation earlier in the pandemic that these critical workers could continue to work despite having had an exposure, but it's not consistent with the current recommendation from the CDC. But we just haven't been able to implement it for workforce for pragmatic reasons.
This is David Kuhar. I'd say for our mitigating staff shortages, for the CDC mitigating staff shortages guidance, incremental implementation or doing it stepwise is what's intended. So absolutely, it's intended that asymptomatic and uninfected or people who are not known to be infected would be brought back first before you would consider bringing back someone who you know or strongly suspect is infected. That's absolutely intended in that mitigating staff shortages document.
And Erica, one thing that we're doing is we're offering an asymptomatic test to these employees about 5 to 7 days after their exposure. So that if they're asymptomatic and positive, we can catch them and we can then exclude them for another 10 days from work. But we are not requiring this of our healthcare workers for them to continue to work.
It's a tricky, but if they're quarantined and tested at 5 to 7 days and negative, they're still being watched for development of symptoms, obviously. But that we're not right now. We're not letting quarantine healthcare workers back to work. So I'm just sort of trying to figure that out. But if they're asymptomatic and tested positive, then of course they would. That's a different category. So do you extend it from 10 days from the positive test? That's going to put them out of work even longer than the date of their exposure.
Sure. Well, so we're not exposing them we're not quarantining them for the first 7 days, right? So they would continue to work and then they'd have their asymptomatic test, but then yes, they'd be out for 10 days if they did test positive there. David, I had one comment for you, if I may. Just when you recommended that you cut back on elective surgeries in order to try to conserve staff members and things like that, my problem has been that not all staff members are created equally, right? Not everybody has the same job descriptions, right? So let's say you cancel elective surgeries, day procedures or something like that. I mean, an OR nurse is not the same as an ICU nurse or as an acute med-surg nurse. And certainly surgeons aren't quite as skilled, in terms of caring for COVID patients or caring for other floor patients as internists, hospitalists, people such as that. So, I sort of struggle with that conservation technique that I think it's good in theory, but when I actually think about our personnel, I don't find that one's quite as good as it seems in theory.
Yeah, I think your points are great. And I would say that strategy is effective differently depending upon the setting. And your points are exactly dead on. Not every provider can do every other provider's job. In fact, people are pretty limited in what they're able to do. So the amount that you're able to get sort of bang from your buck from that one is going to vary a lot. Some settings will be able to get quite a bit, but some, and especially some acute care hospitals where you're right, you can't have someone, an anesthesia nurse necessarily cover, medicine wards, or, you can't shuffle these kinds of things. It's just, you might not get much out of it at all. I know it's a challenge in making guidance that is sort of broadly applicable is that it's not always applicable for every person and for every facility out there.
I did like your suggestion though, to have COVID positive employees trying to do telehealth work. That's something that we're even implementing now, is that if we have a COVID positive employee and they can work from home, we want them to work from home. We don't want them to be home doing nothing. And so trying to come up with in advance work that's potentially applicable to a broad range of professions is something that I think is worth investing in early on, so that you really can put these people to work and keep them working, because I'm sure that's what they want to do if they're feeling well enough to do it, and still contributing to the institution.
Yeah, thanks for bringing that up, Heather. We've had discussions about, the socioeconomic disparities that some of these policies can engender. So if you have folks who can, not take their sick leave and continue to do telemedicine, either as an exposure or as a contact, is that fair that others, who can't work remotely don't have that option and have to use up their sick leave? I think that's a challenging question, and I'm not sure if anyone has sort of some other insights on that. And the other thing I wanted to ask was just, from your representative institutions, how many folks have kind of a different perspective on, allowing exposed healthcare workers to come to work, and, what your decision-making strategy is for switching. At which point do you go from phase 1 to phase 2, or phase 2 to phase 3, or back? If any of the folks from other hospitals wanted to chime in, that would be great.
I'm happy to take that one on. I can tell you globally, so I'm Jim Nide. I am the infection prevention chair at our main hospital. Our group is at 6 hospitals in 3 different hospital systems, and I can't speak to the exact policy for all of the hospitals, but globally, I would echo what Heather Young, her policy is. To my knowledge, I'll just say this, I'm not involved in these decisions. I have found out what our hospitals have been directed to do from a corporate level, and that is to bring back exposed healthcare workers with no quarantining. And I think in large part, that is what is happening. And it has certainly made me nervous. I guess seeing some of Karen's statistics, I wonder if they might not get away with it. My better sense is that they're going to, we have not canceled elective surgeries, but I feel like that's getting a little bit closer. I have encouraged a threshold, just as you had suspected, to say, when do we change this? When do we cancel elective surgeries? When do we start keeping asymptomatic people home? But there's been no threshold that has been decided upon. So there's a lot of unknowns happening at our hospitals. And I would say that globally, it's cited that we would run out of nurses and healthcare personnel very quickly if we quarantine everybody who is exposed at home. And I would just say that this is not an infrequent occurrence right now. My understanding at our hospitals, we're having 10s, 20s, 30 phone calls a day about exposures to healthcare workers. And so it's a very frequent process, a very frequent problem that's getting increasingly problematic. And so I have no specific guidance, only a reflection in terms of what's happening in our community.
Thanks so much. That's very helpful. Dr. Hammer, did you want to chime in? I noticed you turned your camera on.
Yeah, actually, there was some activity behind me that just stopped. So, yeah, I think Jim had some great points. So, we both work in Health One, which is an HCA division, and so basically, I see it as really two tiers of staffing. We have the Health One policy, which, as Jim mentioned, has since day one has allowed hospital staff to work, to not quarantine after exposures and to work while masked unless symptomatic, and then they would test only symptomatic people. But then, and I'm sure Jim as well, all of us probably get calls from physicians. And in our world, the physicians are not employees. And so they don't really work by the same rules as the hospital staff. And what I generally tell physicians and nurse practitioners, et cetera, who are not employees to do is essentially to gauge your situation, to look at where they are. Are they critical? Do they need to go in and see patients after an exposure? Obviously, as long as they're asymptomatic, and to get tested. For those people that have the ability to get tested, they're not hospital staff. They're medical staff or providers who are not employees. I encourage testing, and you can do it at 5 to 7 days, but if possible, I encourage early testing at 4 to 5 days, and then again at 9 to 10. And realizing that a negative test does not necessarily mean that they're not going to be infectious or positive the next day. And they should try to quarantine as long as they're able to.
Perfect, thank you. Marianne, do you want to unmute and share your question? So
I think that Heather answered it. Hi, everybody. I don't work with trainees at this point, but I'm involved in starting the new branch campus up at CSU School of Medicine up at CSU. And there are some LIC students up there, and I'm told they didn't have enough PPE. That may be a little bit out of date. I just wondered what people are doing with trainees. I hope they're continuing to get their education. But I understood there were PPE shortages for some of the people rotating up there in the clinical setting. But I think, Heather, you kind of answered it for me.
Yeah, I think you need to, each school, so I know that the CU School of Medicine said it was all right for medical students to come into contact with patients with COVID or suspected COVID, but each one of the healthcare training programs had different rules. So I think it's always just good to ask the students whether it's all right. Certainly, we excluded students early on in the pandemic because we didn't have sufficient PPE to support extra PPE for learners. But at this point, our PPE has been sufficient that we're able to provide it for them, but something that we keep a really close eye on. For sure, it'd be something that we consider going back to the exclusion, if we were feeling short again.
It's sure a balance between risk and them getting a good education and learning. They were given these what's called half mask. What can somebody explain to me what that is? It looks like a NIOSH respirator. Can someone explain to me what that is? Half face mask.
I think that's the P99, isn't it? Like an industrial with the two filters on the side. David, do you have information on that about whether that's recommended or permitted in this pandemic setting?
Hey, yes. In a bunch of the documents and guidances online, NIOSH has put out statements that, obviously we typically use N95 respirators, but half mask respirators, elastomerics, PAPRs are all alternatives that can be used. The challenge with a lot of these, like PAPRs, elastomerics, comes in reprocessing. It's cleaning them effectively between uses, and they can just be really messy to clean. As a bearded guy and an infectious disease doc, I am a long-term PAPR user, and so I have quite a bit of experience of the mess of trying to reprocess my PAPR a lot.
Yeah, my concern with those has always been the filters in them, that it's just unclear as to when you need to change the filters and whether the filters can sort of like contaminate the outside of your mask a second time.
I'm not 100% clear, but I am fairly certain that NIOSH actually has some guidance on their website about and how to manage and reprocess those devices. I'd have to look. Those don't come up very often, but agree. The challenges with the filters, they're absolutely a place that seem like you wouldn't be able to clean them.
I think they've largely stayed in their boxes and haven't been employed by our students.
We have another question from Karen. I'm going to ask your question, Karen.
Yeah, I'm wondering, listening to the folks on the call, it sounds like many are not able to quarantine their staff. And I'm wondering if they can speak to how they're tracking for possible nosocomial COVID, given the need to have these staff with exposures in the facility.
Yeah, HHS actually requires that we report any COVID infections that happen greater than 14 days after admission. So we report that to HHS, and so we run a report once a week or once every 2 weeks, I think it is, to figure out if we've had anyone. We test everybody on admission to the hospital, so I feel good that if somebody tests negative, that they're probably negative at the time that they're admitted. But other facilities might not test everybody at admission, so that might be a little bit more of a tricky situation.
Are there any data from any nosocomial spread from these hospitals? Has anyone experienced any? And obviously finding someone at 14 days or beyond, they still could have been incubating on presentation. So obviously, I'm sure requires some additional evaluation, and just wondering what people are seeing based on what Heather said.
I can speak just to a few instances, maybe one instance. We're not testing everybody on admission, which we've repeatedly encouraged the staff or the hospital to do. We have come across a case right around at that 14-day mark where we were just discharging a patient with an unrelated medical issue to COVID to a nursing facility who required a COVID test, only to find that the patient was COVID positive. And so certainly what is happening in this instance is the chaos that comes with COVID and backtracking all of the potential exposures. And to be sure, then everyone is relying heavily on healthcare worker exposures and in the CDC table in terms of whether they were masked, whether they had eye protection on, et cetera. So in the real world, in this astonishing finding, an unwelcome finding of a COVID test on discharge being positive. That's, without, I think, the foresight of testing on admission, that's what we're left to do.
I want to get to Bill's question. We also have a comment from Clinton Anderson. And Bill's question kind of speaks to something I was thinking about in terms of not all exposures are created equally. So, how do we prioritize a household contact exposure versus maybe a lower risk exposure? And then I also sort of wondered about, when we let healthcare workers who've been exposed, whether high risk or low risk exposure, come back to work, doing the reassignment that we had talked about, should they be wearing N95s with every patient or simple face mask? I don't know if those questions have come up, but I want to go ahead and let Bill kind of actually sort of more of a comment than a question, but share that.
Yeah, it was just, I'm reflecting on two hats I wear. One is I'm involved with the healthcare system, and I get to ask Heather all my annoying questions about transmission in healthcare settings and how we handle that. And then I spend a lot of time with Denver Public Schools, and the difference is fascinating, because in the school system, we adopt a set of practices that are remarkably different from healthcare, not a little bit different, a lot different. And I don't have an answer to the I didn't pose a question, I certainly don't have an answer. It just seems disproportionate that we have these two settings and we treat them so differently from the management of exposure. So, for example, in schools, if there's a student who's confirmed to have COVID, that class is sent home for 14 days. And even if all of the known interactions in that classroom took place in conditions in which there was high level masking and attention to distancing, we say, well, we can't tell, so the whole class goes home. And just contrast that to the comments you've heard about healthcare workers, and it's just fascinating that we choose to handle these two common and important situations so differently.
Thanks, Bill. It's a spot on comment. And I would like for Clinton Anderson to comment a little bit more about their experience with respirators at the university, if you wouldn't mind, if he's still on. There you are.
Yeah, I'm still on. Give me just a moment. I'm in my command center, so I got to step out here with my computer.
Okay, yep, we can hear you. Okay, give him a second. And Erica, I just want to say thanks so much for sharing your perspective from Salida. I think it's just really important that we get a sense of what's happening around different parts of the state, not just in the large academic centers. It's really helpful.
Thanks. We have the same issues that you guys do. Thankfully, our positivity rate in our community, in our county, isn't as high as the state. So we do all of these measures. We do not let our quarantine providers work. We cross-train all of our nurses to work in different situations, so that all of the OR nurses can work on the med-surg floor or the ER. So we cross-trained all of our nurses to work in all of the units. That's how we're helping our staffing issue.
That's great. And Clinton, it looks like you're available to comment. And also Neil had a question that relates to the same subject. Neil, do you want to unmute real quick, and then Clinton could respond, and then we have to wrap up. We're at 8:30.
Sure. Hi, this is Neil Koo. I'm actually the hospital epidemiologist at the Billings Clinic, and this was during a shade discussion board. There was some buzz about the use, the concerns surrounding the elastomeric mask and the fact that they have exhalation valves, and how to address that, as that would not allow source control if the wearer is infected. So and there's I've heard of some discussion about that there are no specific devices that are used to kind of cover these valves, And so, but there are some institutions are using like makeshift filters to kind of to cover the valves. I'm just kind of wondering if anyone has any experience with something to that effect, because we have some of our employees are using elastomeric masks, and it's really hard because of this issue. It's really hard for us to get them to go back to using N95 respirators, and this is creating a lot of tension between us, the infection control teams, and as well as more particularly the ICU staff and the respiratory therapists, because they find these elastomeric masks much more comfortable. And it's just really hard for them to try to get them to use something else.
I see Heather's comment, and then Clinton, I think yours may be not exactly about elastomeric masks, but I'll give you a second to comment on the university perspective.
Yeah, no, real quick, exactly that point is the reason we use them only in COVID environments right now, just because there's not enough data. In some of the journals, they're suggesting putting over a mask over the exhalation valve, but it doesn't fit well. We're taking a look at that, but there has been a call for NIOSH to really just push on some of the, give us more data on this because they're so widely used. But I'm more than happy just to, and I know someone already emailed me, but share with you kind of the data that we've found and why we're using them in our environments.
Thank you so much. Thanks so much. Now we're at 8:30, so I do need to wrap up, although we could certainly go on a little longer. Victoria, any housekeeping issues that you want to mention?
Yes, please. So I did, of course, put in the evaluation like we do every couple of weeks. So go ahead and take that for this session today. I'll also email it to folks for convenience as well. But I want to make sure everyone remembers we are not going to have a session next week. We moved it to this week for the fall holiday. So we won't actually see you all again until December 8th. It'll be the same time, 7:30 Mountain or 8:30 Central Time. We'll be covering transmission precaution guidelines and rationale. And you're welcome to reach out to myself or Caroline or any of the other planning folks for anything until we see you. But with that, that's all I have. So I'll turn it back to Sarah in case you all want to keep talking or not. I will leave that up to you all.
Yeah, I think we're good to wrap up. And thank you very, very much to our speakers and our panelists, especially to Dr. David Kuar, who came on fairly short notice from the CDC to help us out today. Thank you very much and take care. We'll see you guys at the next one.